Cool. Thank you all for coming. As you're aware, you're being recorded today. You've all signed your forms. There's sign-in sheets going around as well, so make sure you sign into that. I've purposely kind of tried to mix you guys around. As you can see, there's little bits of paper on the table, and you'll work in groups to go through that when we get to it. So today we're going to go through your secondary assessment. Last week we did primary assessment. I don't know if any of you were a part of that session. But we should all know how to do our primary assessments anyway. And really we should all know how to do our secondary assessments. We should have been through this presentation on your orientation day. However, there's been some issues with people not doing their secondary assessments within the department or doing very poor secondary assessments. So we're going over it again today. So it might feel like we're going over things you already know. However, it's not been demonstrated out there on the floor, so we're going to go through it again and we'll try and make it a little bit fun. Alright, so objectives today are define what a secondary assessment is, conduct a secondary assessment using a systems approach, recognising abnormal lung sounds, recognising normal heart sounds, and then recognising abnormal renal, integumentary, can never say that, so skin, CNS, vitals. Just to recap, what we should all know, our A to E, so airway, breathing, circulation, disability and exposure. So that's our initial primary survey, and then we move on to our secondary assessments. So that's our head to toe focus systems assessment, and that's broken up into 6 systems. So that's your central nervous system, respiratory, cardiovascular, GIT, renal and skin. Now what we're going to do now is in your groups, I want you to go through each of the systems that you've got. So there's a front and a back to the piece of paper. You can all write down, or one person can write down. And I want to talk about what kind of presentations need these specific assessments. So who needs a gastrointestinal assessment? Write that down. And what kind of assessments are you doing on them? Just quick brief, and then we'll talk about them later. So go ahead, I'll give you guys 5 minutes to do that.
Well, I had a patient today who had bleeding.
Was it breath patients?
Keep going.
Still need to
CCF.
other cardiovascular presentations, so palpitations or LFCs.
Is this a race?
No, it's not a race. But if you do that, we'll go to
Overdose.
Electrocutions. And then, as part of our secondary assessments, so our
And then how would you assess these patients? What kind of investigations are you doing for them?
PR bleed.
I've got all the
and secondary, do they also include investigations like echoes and stuff?
Just do more nurse related
nurse
stuff.
related things.
Yeah. Focus on your 2 nurse related things.
What do they do nurse related?
So still part of the primary, but
Blood pressure, heart rate.
Some of them might fall under what you do in your primary assessment of these.
and then also part of our cardiovascular assessments is looking at legs, so edema.
That's a CBG. Yeah, keep on.
If you think you've got enough, just flip over and go to the next one.
Spirometry test.
So colour.
Cap refill.
Spirometry one's good, we don't do that very often. I think we've stopped doing that because of COVID as well. So it's not really doing that at all.
I don't know if I told you.
So head to toe skin assessments, yeah?
There's lots of big ones as well, if it's hematemesis, that one and that one. We do
Trauma patients.
these as well.
Nursing home patients.
Really, it should be all patients.
That's what I was, when you said hospital, I was going to say it's undressing.
Yeah, and inclusive of undress
Fluid assessment.
patients.
I guess trauma is a full.
Yeah.
Derm patients.
Like trauma and treatment patients.
I had a lady come in with that rash everywhere last night.
Don't forget your
Yeah,
birds.
there were some renal ones as well. Let's do that.
You guys are a bit too quick.
Burns.
No.
Wounds.
Hey, come on in.
I'm trying to.
Just so you know, this is being recorded, so if you have to be recorded, great. Maybe jump on this team down here.
Is it alright?
So they're just working for renal at the moment.
I think so.
Or if they're
Skin
having,
turner.
what we're doing is we're talking
I
about
do. I'm a shit
renal
scholar. I
retention.
did not realise. That's why my writing's usually really horrible. Looking for
Overdose patients.
pressure sores.
Something that causes retention.
So wound assessments. So
ODs.
tracking
Flag pain.
measurements. Wound swabs. Cellulitis
Some
patients.
patient coming here is like, renal presentation, fistula,
Oh, so that,
Dialysis patient.
dialysis.
or slash dialysis.
And then that can also go into
Patients who have chronic conditions.
tracking.
In some instances, take photos and also mark.
Squeeze in somewhere.
Allergic reaction.
As well, it can affect your kidneys.
Hey, see.
They've got angioedema.
We're just going through, just so you know you're being recorded as well, the camera's just up here.
Assessing
You have to be
for
recorded. So anything you talk about will be recorded. We're just going through secondary assessment today.
Okay, what else? And then
And we're
how do
just
you
in
assess
groups.
this? So,
You might want to jump on there in group. I think they're nearly finished. We're just going through what we need to do for secondary assessments for each system. And then we're going to talk about it. How's everyone going?
I think that's pretty covered.
Alright, let's talk about it. So first,
I don't even have the same thing.
central nervous system is the first one. So this group over here. What kind of presentations do you think need a CNS systems assessment done?
I was Skype, so you do.
How's these fair? How's these fair?
Mechanical fall, MVAs, trauma, hypernatremic patients, stroke, seizures, epilepsy, OD, altered conscious states, ABIs.
You guys heard a lot, yeah.
Yeah, we did.
No, it's good, it's really good. Anyone add anything there?
TBIs.
What did you say, sorry?
TBIs.
Yeah, traumatic brain injuries, yeah, which
Which
could be
that's
from your
trauma.
MBAs and trauma. Yeah. And what investigations are you doing, or how are you doing your assessments on these patients?
So we're doing GCS, neurobs, pupils, Sapella, walk test, ACE, bloods and alcohol level, AWS, MENS and C-SPAD.
Anyone have anything to add there? Yeah, you guys are pretty thorough. Let's see what I've written. Not a lot compared to you guys. So we're just looking at the general appearance and behaviour of the patient as well. Have they had a head stroke and now their behaviour is really bizarre and odd out of, what's normal for them? Conscious state, which you guys said, which is again looking at the best verbal response, pupil size and response, motor response, orientation and posturing. What do you think we're talking about when we mention posturing? Or can anyone think of what the two terminologies are called in parts of your GCS? Or does anyone know what this looks like or what this, yeah. Does anyone know what?
Cerebit and
Yeah.
corticate. Yeah.
Yeah, so decorticate is contracted up towards your
Oh,
body.
yeah.
That's how I remember. Corticate, you catch a ball. And then deceribit's the other one. When they're, posturing's away from the body.
And what do those indicate?
So that indicates like usually someone's having a seizure, or if it's prolonged, then it's to do with an injury at the brain. So they might be brain dead, or they might have an injury in the spinal cord. Yeah, so it's not a good sign at all.
And changes also like increasing intracerebral pressures from
Yeah.
bleeds and stuff like that as well.
So their GCS will be really, really low if they're like that. Yeah, it's not a good sign. Okay, what do you think's happening here on the top? What does this look like? Great. This one here?
Maybe
Equal, unequal, unequal. And this one here, it might be a bit hard to see where you guys are. Also unequal, yeah. What more information would we like to know when we're assessing these patients?
If
any
it's
weakness or
some people can have a normal,
Perfect, yeah,
some
absolutely.
irregular, well,
Yeah, so we asked our patient if they can answer, or we asked the family members, is this normal for them? And it might be normal for them.
What's their blood pressure like?
Yeah, And what about the one on the right?
Looks like
What
the
have they
bloke from
taken?
down the road the other night, having his own little hut.
Yeah, so this could either mean if they're fixed and dilated, brain death, or usually a little bit smaller than this in both eyes, could be like a drug affected.
Or had they put drops in
Yeah,
to
yeah.
dilate the pupils too.
Yeah. Alright, what do we think is happening with this patient here?
Stroke.
Yeah. What else could be a differential diagnosis for this patient?
What's that?
Bell's palsy?
Bell's palsy.
Yeah.
There's another one I had recently, and it's something to do with like numbness and tingling of like coming from the ear, like an ear infection or something.
Right, okay. Is anyone familiar with that?
Vertigo?
I'll have to follow up with the name.
I'd be concerned if vertigo was making me have a facial
What's Justin Bieber got?
She wouldn't blink. Yeah, it was the same as that.
Yeah,
It was the same as that.
I forget the name of it, but that
It's
is
not
very
myasthenia
similar.
gravis or the,
Oh, maybe
Google it.
Yeah.
Yeah.
there's another one as well.
What is that
I
one?
can't think of what it's called. But yeah, it could be a Bell's palsy as well. So Bell's palsy is a viral illness and it's only going to affect the face. They're not going to have limb weaknesses. We should go with that. Respiratory system. Who's got respiratory? Pressure's on. So I want to read out what presentation. Oh, over here again.
Yeah. It's a Ramsey Hunt.
We've got a shortness of breath, asthma, COPD, chest infection, pneumothorax, emphysema, pneumonia, anaphylaxis, APO, COVID, RSV, and influenza.
Yep. And what investigations are you going to be doing for these patients?
Chest auscultation, respiratory rate, if the trachea is midline, auscultation, chest x-ray, VBG, ABG, checking the SpO2, spirometry tests, work of breathing as well.
Yeah, respiratory patients are needy, aren't they? They're hard work. And you've basically just said everything that I've written up here anyway. So we really should be having our stethoscope, especially in the height of COVID, making sure we're doing a chest auscultation on every patient that comes through our cubicles. And we're actually going to have a listen, and this is how we do a lung auscultation as well. So starting from your left or right and going across to each side and working your way down. I'm going to play a video for you guys. And I'm hoping you're all really well versed on this anyway.
Adventitious breath sounds. Stridor. Stridor is a continuous high-pitched crowing sound predominantly on inspiration. The cause of the sound is generally the partial obstruction of the larynx or trachea. Stridor may be heard in conditions such as croup and foreign body obstruction. It's typically loudest over the anterior neck as air moves turbulently over a partially obstructed upper airway.
So it's always upper airway. And you can usually hear it coming a mile away.
Wheeze. The sound of a wheeze is a high-pitched continuous musical sound. This is caused by air passing through an obstructed narrow airway. The classic wheeze may be referred to as a sibilant wheeze. This refers to the high-pitched whistle-like sound. Alternatively, what we often refer to as ronchi is the sonorous wheeze, which refers to a deep, low-pitched rumbling or coarse sound as air moves through the tracheal bronchial passages in the presence of mucus or respiratory secretions. It is commonly heard in the lungs during expiration. It may be heard in asthma, emphysema, and chronic bronchitis.
A little bit hard to hear, but I think we should all know what a wheeze sounds like.
Crackles. Crackles are also known as alveolar wails. The sound crackles create a fine, short, high-pitched, intermittent crackle sounds. The cause of crackles can be from air passing through fluid, pus, or mucus. It is commonly heard in the basis of the lung lobes during inspiration. Crackles can be further categorized as coarse or fine. Coarse crackle sound quality is low-pitched and moist. It may be heard in pulmonary edema and bronchitis. Fine crackle sound quality is like hair rubbing near the ear and may be heard in congestive heart failure and pulmonary fibrosis.
What kind of patients are we going to hear this in? Yeah. What other kind of patients?
Pleural rub.
Sorry?
Pleural rub sound results from the rubbing
Yep,
of
absolutely.
inflamed pleural surfaces against one another.
Yeah, it's
during
real like a
chest
wet
movement.
sound in chest. Or it could be like
Sound
a
quality is
wet
considered a harsh, grating, or creaking. Potential causes
This one I
include
find really
tuberculosis
hard to
and pneumonia.
hear
It's
in
best heard in
practice.
the lower anterior lungs and lateral chest during both inspiration and expiration.
So that sounds crackly to me. I don't know about anyone else.
prescribed
chest
and visit
auscultation.
osmed.
Good, who say good? Yeah?
You said that.
Is anyone not so confident? Like, that's completely fine to not be confident with it. No? We're all happy to go out on the floor and do our chest auscultations and document it okay? I know for me, it took me a long time to, you know, distinguish between the different sounds and then actually appropriately document. And it does come with practice, so have your stethoscope and just keep doing it if you are new to it. Cardiovascular. Girls in the back seat. Back row.
Alright,
Kind of
so
presentation.
for this presentations, arrhythmias, arrest, seizures, chest pain, shortness of breath, and some respiratory presentations. CCF patients, palpitations, someone who's had an LOC, drug affected or overdoses, electric shocks, trauma patients, and those with renal impairment as well.
Yep.
And then things like our ECGs, TROPs, auscultating, chest x-rays, your normal observations, palpation of pulses, looking at like peripheries, for your, is it colour warmth, pupillary refill?
Yep.
Looking for signs of peripheral edema, utilising medications.
Yep, sounds like you guys have covered it all. Does anyone want to add anything? So I guess this kind of falls under your C or your ABCD. So just recapping, so we're looking at skin perfusion. Usually someone that's having a heart attack is really sweaty, diaphoretic and like grey looking. So I'm looking around the room now and we're all looking nice and pink and well perfused looking, or nice and tan over here. Tess. A little bit jealous. Pulses, having a feel of pulses and having a feel bilaterally if appropriate. Are they equal? Do they feel the same? Heart sounds, which we will talk on shortly. Heart rate and rhythm. So again, you can feel the pulse. Does it feel regular? Does it feel strong? Pop them on the ECG and have a look. Doing a pain assessment if they're coming with some chest pain using your PQRST, which we spoke about last week. And blood pressures, if indicated, doing bilateral blood pressures or doing a lying and standing blood pressure. Ventilators are back. Is that what that was? Only the things that we need to keep the patients alive aren't back. Blood scanners here. When would we do a right and left blood pressure?
When there's a dissection.
I didn't hear any of that.
Query
Query what?
dissection.
Dissection. Okay, good. And what about a lying and standing blood pressure?
Syncope.
Yeah, syncope is probably the most common, or someone that's feeling dizzy. Alright, we're just going to quickly talk about heart sounds. I know this isn't something that we, you know, regularly do here on ED, and it's not a skill that we expect you guys to be doing on every patient, but it's just good to know. So a lovely picture here has lots of information going on, but basically when we're auscultating, we just want to auscultate at S1 and S2. So it's kind of down here at the peak and up here at the top. And does anyone know what we're listening for? Love dub. Yep, perfect. Love dub, and let's play a video for you. I don't want you guys to really know or diagnose anything else, as long as you can listen and go, yep, that's love dub, great, or no, that's not love dub, I'll let the doctor know. This is love dub. That's all you want. And it might be faster or it might be slower, depending on the patient's rhythm. Has anyone actually done that with a patient before?
Mm-hmm.
Yeah.
Yeah. Gastrointestinal. Alright, what kind of presentations are you guys thinking?
Okay, we have PR bleeding, hematemesis, anyone with abdo pain or constipation, anyone with nausea, vomiting, diarrhea, or like gastro symptoms. And for assessment, we'll do palpation in 4 quadrants, auscultation in 4 quadrants, and look at the patient's like volume and hemodynamic status as well.
And what would you do first, auscultation or palpation? Auscultate. And who can tell me why we auscultate first?
If you palpate, you can
Lose
changes.
Yeah. So we always look, listen, and then feel. So we do feeling last, so we might disturb stuff and create bowel sounds that might not have been there before.
Or pain to the patient.
Yeah. When would we not palpate an abdomen? No one know?
Is it when you're querying like a aortic?
Triple A?
AAA, yeah.
Abdominal aortic, yeah. Yeah. So obviously if they've got a suspected triple A, so an abdominal aortic aneurysm, it's in the abdominal region. and it's like a little ballooning of the aorta, depending on the type that they've got. And if we press on that, we could actually burst it and make it worse. So we just don't. So yeah, GRT. So we assess that abdomen, dividing it into your 4 quadrants, looking for signs of swelling, bruising, any scars, auscultate bowel sounds, palpate, and then we're asking questions like, is there any nausea, diarrhea, constipation, is there pain? And this is just a lovely picture here of how we divide our 4 quadrants. You can go much more detailed if you want, but this is nice and simple, straight to the point. You know, left upper, right upper quadrant, right lower, left lower quadrant. What other assessments can we do? So we've got auscultation, palpation. What's the third one we can do that we don't do very often that you might do? Yep. That's where they kind of put their fingers on it and they tap and they're listening for the organs and it sounds different. Which one do we think is which? We might never know, but she's wearing nice underwear. She looks female. And this is actually a real photo from the internet of a gentleman with ascites. They just got him to go in that position, so he looked pregnant. But so I guess if you walked into your cubicle and you saw this abdomen on a 40-year-old male, what are your assessment findings, and what are you going to do next? What are you going to look, listen, feel? Yep. And what do you think's wrong with this man?
He drinks too much.
He's got a side. He's being judgmental. Yeah. You might want to join him on the weekend for a few more drinks. All right, renal. What kind of presentations are we thinking?
Okay, anyone with chronic kidney disease or patients undergoing dialysis, anyone coming in complaining of retention or any problems with urination, anyone with flank pain, patients with things like CCF, and patients who come in with an overdose on certain medications as well, patients with diabetes too. And to assess, we'll do bloods, looking at like their EGFR and their kidney function, assessing urine output and their fluid balance, do a full ward test, and that's it. That's all we've got. And a blood scan.
Yeah, well, now that we have one.
I was like,
That was going to be prompting. Can anyone add anything to that? We're all pretty happy with that. So I guess renal's actually a nice simple one. So we want to look at urine output. Do they have a catheter? Do they have like an IDC or an SPC in situ? Is it draining well? What colour does it look like? We also probably want to think about forward tests, beta HCG if they're of childbearing age as well. And we've just written here as well. So the normal urine output, so for you and I, healthy adult, is 1 mil per kilo per hour. From 70 kilos, and they need to be 70 mils per hour. Which I don't know about anyone else, but I don't make that at work. All right, skin.
Back to us.
Skin's much easier, so.
So there's a whole series, but really every patient should have a skin assessment. But in particular, people with like skin infections, trauma patients, nursing home patients, any dermatology presentations, burns, wounds, ulcer, cellulitis, bites, allergic reactions, and to assess for dehydration.
Yeah, I think you really hit the nail on the head there. Every patient pretty much needs a skin assessment. It takes us 5 minutes to undress our patients and then document skin intact, unless we find something abnormal.
Yeah. And then with that, you can assess obviously skin turgor, look for pressure sores, document them, do wound assessments and wound charts, take swabs, cultures, photos. We probably wouldn't, but like, you know, sometimes units might do that. As also an assessment for things like pitting edema that might prompt you to assess for other things, and then outline areas of like erythema to assess for spread.
Yeah. Skin's really important. It can tell us a lot about a patient. When we look at them and they're pale, or what's their HB doing?
Yeah.
Look at them, they're grey, and they're clutching at their chest. They might be having a STEMI. We look at them and they're yellow, so they might have jaundice. Yeah. So it actually can tell you a lot of information. Jaundice is very aggressive there.
You go, girl.
So yeah, there's some pictures here. So that's very true. So as Steph was saying as well, swelling there, edema, what are we thinking could be the wrong with this patient here?
CCS or exacerbation.
What about this gentleman down here that says he has no history, he's got a bag of meds with him, but I'm fine. Yeah, yeah, looks like he always had cancer or something. Yeah, had open heart surgery of some kind. And then the lovely little old lady from the nursing home. Yeah. What are we going to do about this lady here? Wristband. Document.
Some cream and some dressings.
Poor thing. So to summarise, we've just been through our 6 secondary assessments. So central nervous system, respiratory, cardiovascular, GIT, renal, and skin. Now, has everyone got their phone with them as well today? Got to
Let's
say,
do a
if we can whip that out. We're going to do a quiz.
Get on the quiz. I'm ready. I'm ready for this one
This
now.
is where the chocolates will come
After
from.
last week.
I forgot that we had chocolates. Quizzes.com. And then we've got one more fun activity after this.
.com/what?
.com/join.
Oh, do we have a code?
Mine's not ready. What did I do wrong? Quiz ISS.
It'll come up in a second, I'll show you guys in again.
Is it .com?
Yes.com.
Oh. /
There's the link there and the code.
937972. Join a game.
Hang on a minute.
Too bad. I'm already in.
937. 937. 972.
Boom. Oh, I'm a sloth.
How do I write my name here? What if I'm really wrong?
You don't have to put your name, but then you don't get chocolates, so I don't know who to throw it at if you do well.
Oh. Depends how badly you do it.
There's only like 6 questions.
I was going to say, I'm going to put my name in as back 10. And
One more person.
You actually did?
Yeah.
no, I think that was probably someone else, wasn't me?
Anyone else? Are we waiting on anyone?
It wasn't me.
Should have put bird.
My name.
Just put your initial.
Are you in, Jared?
Yeah.
You're in? Who's not in? Okay, you're right.
Jay.
Alright, let's get started.
I'm ready.
So I think it'll all come up on your phone. I think there's just a bit delayed up here. So.
Oh, I got that wrong.
There's clues in there.
So you get more points if you answer quickly, but also make sure you read the question. Jared is still in the lead, he's on a streak.
Yeah, mine's really slow as well.
Don't blame the internet.
Don't blame them.
Sarah's jumped in the lead, Robert Evans in the lead now.
No, stuff he does.
Susie in third.
Oh, I don't care about Harry and Meghan. Get off my screen.
Oh, damn it. And the questions at the end are points based. Oh, damn it.
Lizzie died. Give me a break.
It's a rough day, okay?
Oh, shit, I said the wrong one.
Oh,
Get into the
bloody
lead.
hell.
My fair bit, mind you.
What the hell?
I like the would you rather.
Yeah, but we're doing it just for fun.
Yeah.
Yeah.
Surely I'm getting another 1,000 because Lizzie died.
Are you related?
No, probably someday I'll look wrong line.
Does it count if you're like technically like married into it? Liam's related somehow, like somehow many
Does
times
it count if your
removed.
middle name is Elizabeth and you have royal blood?
Don't know. Maybe.
10 points for Simone.
Alright, one point and one more person.
Oh, 100%. I got one wrong.
I'm
Fucking
done.
hell.
So we'll go through the questions and more importantly the would you rathers to see where everyone's at. And then we've got a game here to play as well. Yeah,
Woo!
what chocolates would you like? Do you want to take some home or give some to someone that's having a bad day? And who have we got next? Who's Jay?
Oh, Josie.
Who's Josie? Let's take whatever you want.
Nice.
Take one from me to
And Sarah. What was that?
What?
It's nice. It's nice you've got a good mix. Alright, let's go through the questions. So the first question, what secondary assessment would you perform for this patient with epigastric pain and shortness of breath? This one probably could have had 2 answers, but I did put the first one because often epigastric radiates into the chest and into the abdomen, and they were feeling short of breath, so respiratory as well. So 9 people got that one. Second, what could basal crackles on chest auscultation indicate? Select all that apply. So we said APO pneumonia. So we got 9 out of that as well. What's wrong with this image?
It took me a second to work that out. It was his stance.
Yeah.
His stance.
I was envisioning.
It was actually really hard to find a picture of a patient on Google that's fully dressed in bed. But that's the answer. It's fully dressed. And all of you got that correct, so excellent. We all got this correct, so yes, standard urine output should be 1 ml per kilo per hour. Abdomen divided into 4 quadrants, great, we all got that. What's this one called again?
Decelerate.
Decerebrate. Did someone say decelerate?
That was me.
I love how so like
Love it, love it.
you're like really quick to
Alright, would you rather? So, EMR to be down or EDIS to be down?
EMR.
Yeah, so 4 people said EDIS, but yeah,
I said EDIS only because EMR's got
all the meds.
the meds and
Yeah, but
confusion.
Nah.
When Edith goes down, Narina's got her amazing whiteboard.
Yeah.
So that helps.
It might depend where you work as well, so if you work out of triage, you might not want to EDIS to go down.
At least the worst.
Yeah, but who's-
directly to the doctor.
in the old days when we didn't have EMR, it was great not having EMR.
Yeah.
Just do everything on EDIS.
It's true.
I panicked.
Would you rather a pleasantly confused wandering patient or a non-violent chatty mental health patient? This is 50-50. I think I have more tolerance for an elderly patient.
Yeah, elderly.
Wondering is too stressful. I feel like I'd rather be like, oh, I'm really busy. I'm so sorry.
I
I've
feel
got
like
a chatty mental
wandering
health
is a
patient
risk
and
one
leave.
waiting to happen.
Yeah, if they're safe on their feet, wandering is probably not so bad, unless they're going to wander into traffic.
You get stuck in that room with the chatty mental health
Oh
patient,
yeah, no thank you for
At least
this.
you're out walking around.
Now, would you rather put in IDC or put in an NGT?
IDC.
Yeah.
For sure.
Hate NGTs.
NGTs, you're not for me. Oh, sorry, who said yes to the NGT?
I'm
I'll
coming
be
to
finding you
every
guys when I
single
need an
time I
NGT
need
put
an
in.
NGT.
Come on, find you.
Choose it was also way aimed to the brainstem.
And would you rather chew your own toenails off or chew someone else's fingernails?
Oh fuck! I didn't say that it said. I didn't say that it said toenails.
I'd rather my toenails because I'm that big and I can't even reach them. So I'm sure enough.
I'm not going to ask who that is.
Y'all are some sick freaks.
Alright, so we've got one more game. Now I'd like 2 junior people to volunteer to come up here and prime a pressure bag, and it's going to be a race.
Ooh, girl.
So I want 2 people that haven't done it before, and then I want 2 seniors to come up and tell them how to do it without physically touching it.
I've done it before, so I'm not.
Oh,
Yep.
damn. Do we have juniors that haven't done it before?
I'm looking over here, I'm looking over here. Come on girls, race each other.
Race each other.
Do it.
Who wants to come show them, well not show them, tell them how to do it?
Rosie and Susie.
Can I go so I can, I've got to pick my mum up from
Go,
the airport,
yeah.
sorry.
No, you're right. Oh, can you just fill this out before you go? You too.
Oh.
Come on.
Haha.
After we've done this, we're done.
I'm terrible at instructions though.
So, you guys aren't allowed to touch it. You have to tell them how to do it. Give them some instructions first. And then I'm going to go say go and you're going to race. Right.
So are they whispering so they can't like?
It's up to them. That's what kind of tactics you want.
We start?
Don't start, she's going to tell you how to do it first and then you can do it. These guys are following. And you can talk them through it as they're doing it as well, but also ready, set, go.
Yeah, okay. Feel that bit?
Alright, you girls ready to go?
Yeah.
Ready, set, go.
Do what I said, Sarah.
Messy positions here.
Yeah.
And I will be checking for air bubbles.
Yeah.
No.
Squeeze it. Alright, now we're going to start letting you.
I'm done.
I don't think you're done.
Yeah. Keep going.
How are you going to fill it up?
Keep going.
Flip.
Bam!
Yeah, I think we have clear winning
Well,
here.
it's time today.
So this was a bit more chaos. So this was a bit of an example about how communication is really important. Because what happens when we panic and have a little bit of a breakdown in communication. So she was taking her time, got there in the end, and still won. Not that it's important about winning. So it's just an example of how our paperwork needs to be up to date. Someone else should be able to come in, read your notes, and know exactly what's happening with your patient, and take over care from there. Yeah, I'll just go. I've got some feedback forms for everyone to fill out as well. Is there any questions that anyone has today?
Totally.
Yeah, you can start. Thanks, Steph.
Yeah.